welcome everybody to the first edition of Sientra TECHnews series. So this series is designed to talk to the experts in plastic surgery about how to achieve optimized outcomes in safety and results using the most sophisticated techniques and technologies to achieve the needs of each individual patient. So I'm very pleased today to be joined by an expert panel of world-renowned surgeons in achieving just that. So first off, out of Dallas, Texas, is the Dr. Bill Adams.
Full throttle. It's great to be here. Thanks for having me. It's great to be here with Brad and Bruce and Rob. It's going to be awesome.
Thanks, Bill. Glad to have you as well. And so next on the panel is Dr. Bruce Van Natta from Indianapolis, Indiana.
Hey, Blaine, and hey, gentlemen. Glad to be with you all. This is a great group. Should be a great discussion.
Thanks. And next on the panel is Dr. Brad Calobrace out of Louisville, Kentucky. Welcome, Brad.
Hey, thanks. I'm really looking forward to it. These are all my friends here, and I know we've all talked about this 1,000 times, and I'm sure we're going to have some healthy conversations in just a minute, so I'm looking forward to it.
And last but not least on the panel is Dr. Robert Cohen, who has practices in Beverly Hills, California, as well as Scottsdale, Arizona. Welcome, Dr. Cohen.
Thank you so much, Blaine. Really looking forward to talking to you guys about some topics that are really important to all of us.
Great. And with that, we're going to start with Dr. Cohen reviewing some presentation on that'll get us started with techniques and technology and optimizing outcomes. So Dr. Cohen, if you'd like to take over and give your presentation, that'd be great.
Thank you, everybody, for watching. I think this is going to be a pretty interesting discussion today. Breast augmentation, breast surgery is a near and dear topic to my heart. It's something I've been interested in and very focused on since the very start of my career. I've always really been focused on being an evidence-based, science-based surgeon. I think it's really important. That applies to techniques in terms of always trying to advance techniques and try to do whatever is sort of going to give our patients the best results and the safest results. But that evidence-based view of surgery also applies towards materials and devices such as implants, which I think is really important. So I think this discussion today should hopefully be very helpful. So my introduction with Sientra implants actually started right at the beginning of my practice when I started my fellowship in 2004 with Dr. Grant Stevens. We had access to these implants. And I knew at the time there was something about this implant that I really liked, although as a fellow, I didn't really have the level of knowledge or experience that I obviously have now. So all I could say was that I liked the way the implants felt, I liked the way they looked, I liked how they sort of seemed to do once we put them in patients, but I didn't have a great understanding for why. And as things progressed along a little bit further in my career, when Sientra came back on the market for everybody, the first thing I sort of learned about this implant that made it different than some of the other implants I'd used was the shell-gel interaction. And what was really great about these implants is that the implant gel was very adherent to the implant shell, which made the entire implant almost one cohesive unit as opposed to two separate things. And the way that I noticed that, not just in terms of hearing about the science and seeing data like on this slide, was just in practice. You know, when I was in my office and I have all these different brands of implants sitting on my desk, I would notice that a lot of the implants would start to delaminate, the shell would start to delaminate from the internal gel. And I really never saw that with Sientra implants, even though they were my most handled and most used implant in the office during my discussions with patients. In the operating room, same thing. I was noticing that sometimes I would open up a brand new implant to put in a patient, and the non-Sientra brand implants sometimes would already be delaminated a little bit before we even got started. A couple cases enough so that I actually called the rep and tossed the implant and put a new one in. And just for reference, you know, I've used every style implant, so all three brands: smooth, texture, round, anatomical. I've put them all on patients, and I've had experience with all of them. So this is something I knew I really liked about Sientra, was this sort of cohesive unit of the implant. But that wasn't really enough to explain why I like the implants. And I like the way they felt, I like the way they looked, but that's not really enough. You know, just saying it feels good isn't really very scientific. So a number of years ago, it was actually Blaine who pulled this slide for me. And before I get to that specifically, I do want to talk about some of these bullet points on the left, which I think are really important, which is what is an ideal implant? What do we want out of our implants? So obviously we want an implant that's very strong. so it doesn't fracture easily. It holds its shape over time. But on the same token, one implant that's going to be soft and feel like a breast, because what patients don't want is they don't want it to feel like there's a foreign object stuck in their chest that's different than their natural body. Ideally, they want to not really notice that they have an implant, but feel like the implant and the breast are all one unit. I know Brad talks about that a lot in his presentations as well, as sort of the concept of having a unified breast where the implant and the breast tissue act as one. So this slide was a real aha moment for me. When I first saw it, suddenly everything kind of came together and made a lot of sense to me. So as we all know, there's sort of a correlation between strength and firmness of an implant. So as an implant gets stronger and has more cross-linking and more cohesivity, the implant's going to start to feel a little bit firmer. And that's a trade-off that we are aware of. But what I didn't really understand at the time, and after I saw this slide and really started thinking about it more, it made a ton of sense to me, is that the ratio can be different between different brands of implants. So if you're looking at this slide of the x-axis, you're seeing that as the implant's going to get firmer as we go to the right. When we look at the y-axis, as we go higher, the implant's going to get stronger. So, a lot of people sort of have this idea that we have to have, if you want a really strong implant, it needs to be a really firm implant. So that's kind of the notion that we get from, let's say, the Allergan cohesive implant, which is a very strong implant, but it's also a very stiff implant. So what we see here on the Sientra line is that the strength goes up without adding as much firmness as some of the other brands. So if we look at the regular Sientra HSC gel, which is their standard implant, which is priced pretty similarly with the responsive or the standard Mentor implant, you'll see on the strength level, it's basically at the same strength level as the Allergan cohesive, which is pretty surprising. But if you look at the softness, it's softer than a soft touch. It's somewhere in between a responsive and a soft touch. When we go up to the HSC Plus, which is the Sientra's stronger gel, that is significantly stronger than the cohesive, and yet it's still softer. It's somewhere in between the soft touch and the cohesive. So this is really important because we get all the advantages of a very strong implant where it's sort of acting as one unit and it's going to be more resistant to rupture and deformation over time. But at the same time, the implant's still going to maintain its softness. And one of the problems I've found with using cohesive implants, particularly if you're using a higher profile cohesive, is that stiffness. So the implant doesn't have a lot of give. So with the Sientra, either HSC or HSC Plus, there's sort of a springiness to it. So the implant will move and shift and conform to the patient's body as they're moving around. So it feels more natural. It's less likely to cause wear and tear on the tissues. Whereas with the cohesives, there were situations where the implants would actually flip in the pocket. And I know myself and a lot of my colleagues began to be fairly reluctant to use those implants, especially in the larger, higher profile varieties, because of this possibility of the implant flipping in the pocket, which was really bothersome to patients and sometimes required reoperation. So I think this slide is really important. Now, Blaine's going to go into a lot more detail in a little bit about some of the science behind this because his level of expertise on that particular topic is higher than mine. But I think just as a surgeon, understanding that you want an implant that's soft but also has strength, that just kind of seems obvious to us. And if we can have a product that has both, then that's kind of the ideal situation. So I'm just going to run through some basic cases that I've done where I've used the Sientra implants, and we'll obviously open everything up to discussion. So just show a few straightforward cases first. So this is just a breast augmentation using the Sientra HSC implant 415 moderate plus. This is a younger patient who wanted a lot of upper pole fullness, but still wanted to maintain a soft, natural appearance. As you can see, a year out, she has a really nice natural look. The implant's holding its shape and position very well. Here's another patient with a little bit of a wider spacing in the cleavage area. As you can see, once again, nice fullness. This is a little bit of a less projected implant because she had a little bit more natural projection. This is another example. I know not as many people are using textured anymore, but this is an example of Sientra textured anatomical moderate profile classic base, 350 cc's. And as you can see, a very natural slope in the upper chest, good upper pole fullness, and nice stability. Now, as we get to more complicated cases, that's where if anything, the implant selection matters even more. So this is a case of a patient who had very oversized saline implants. And as you can see, she had a little bit of a superior malposition with a waterfall deformity. In this situation, I had to open up the upper pocket, popcorn the lower pocket. I downsized her from about a 600 cc overfilled saline to approximately 450 cc moderate plus HSC gel implant, and did a mastopexy at the same time. Obviously had a tummy tuck as well. And so for this patient, you want to make sure over time they're going to have a low risk of rippling and irregularities, but also make sure the implant has good strength and support and stability. There's another case where a patient had a subglandular overfilled saline implant. This is a patient where I did a preoperative deflation, and then I ended up switching her from a subglandular submuscular plane, adding a reinforcement material, switching her from the saline implants, which were too large for her. She was also probably close to 600 cc range, down to a 450 cc textured anatomical in this situation, and a vertical mastopexy, although the scars are pretty well faded at this time. And you can see she's maintaining a very nice upper pole fullness, but a much more natural blending. So anyway, those are some examples. Honestly, the implant selection is very important. Technique is very important. These are all different factors that need to be combined in order to create the best possible and the most optimal result for patients. So it's not like you can, keep the base width and do this and that and then put in an inferior quality implant. You sort of owe it to your patients to do the best work you can, provide the best techniques possible, but also provide the best materials possible as well. And as technology keeps advancing, we need to stay up with the technology and not just use the same things we've been used to using for the last 10, 20 years. I'm going to actually give things over to Blaine here to talk a little bit more about the science behind these implants and explain maybe at another level beyond what I can explain why I love these implants and why I think they work so well for our patients.
Thank you, Dr. Cohen, for that presentation. I think that's extremely helpful to see how you went through your process in evolving your techniques and the technologies you were using. Before we get too much into more of the science, I'd love to ask the panel, what I saw in your presentation is that you are very specific in using different techniques and different technologies to achieve the intended outcome for each specific patient, which is not all the same. And a lot of the surgeons I talk to, when I ask them what kind of things they use and what techniques, it's very consistent every time. And we've seen this in the data too, that our long-term results have shown that as we looked at factors that look towards capsular contracture or rupture, that the people who are the most thoughtful with each individual patient and use a spectrum of techniques and technologies are the ones who get the best outcome. So I'd love to hear from the panel on how that has affected your practice.
The one thing I'd throw out, and Brad and Bruce can maybe elaborate, but for 30 years now, we've been trying to advance the device. And certainly a lot more goes into a good result than just a device. But the thing that's changed, 30 years ago, people started to recognize that the patients that had the nicest shaped breasts had a very nice control of the distribution of fill within the breast. So they started trying to play with controlling the distribution of fill within the implant. That gets into kind of some of the stuff that Rob talked about. So I think most surgeons would recognize that with the experience in saline implants, that the predictability was worse. You saw more stretch over time, and that's mainly because we weren't controlling the distribution of fill within the breast as well as we can say now with these new devices. But all the devices should not be generalized. They all are individually different. And I think what Rob's shown is a nice comparison between some of the available implants out there. And the sniff test, he was just talking, he liked how it felt and how it looked. That may not be the most scientific thing, but there is some validity to that. When you hold these things in your hand, you can tell this shell feels thicker than this shell, or this gel feels firmer, or this implant you can't separate from the gel shell interaction. So all those things are relevant. And I think that what Rob showed scientifically is very valid in terms of what we've seen over the past, especially the past 10, 15 years with the newer generation implants. So Brad, Bruce, what are y'all's comments on that?
Well, mostly what I would say is that, every result looks great on the table because the implant has not been affected. The soft tissues have not been affected by the implants. But at the end of the day, the soft tissues are not going to control the implant well. And so if the implant itself isn't controlling its shape, it's going to all fall apart over time, every time. So what's been the advance in implant technology, the ability, as you mentioned, Bill, for these implants to hold their position within that shell and thus hold their shape and give longevity of the overall results. That's been the game changer, and it's not just the fill, whether it's saline or gel, but it's definitely what's the cohesiveness of the gel, what is the gel to shell interaction, what is the fill ratios or the optimal fill of the implants, all can ultimately affect how it performs over time. But the more control, as you said, that the gel has and the implant has to hold its shape, the better job it will do at holding the shape of the breast over a period of time.
Yeah, I would echo the comments that both of you have made. And I think it's important to recognize too that as we've watched the advancement, the development of these devices over time that the failure rate is going to be impacted by this. And we had that hinted at in the core study of Sientra's, and looking at that, particularly if you broke that down and saw the really low failure rate compared to some of the other manufacturers. So these things are important in terms of tissue interaction, but they're also important in terms of the long-term viability of these devices, which is also very important.
Yeah, that gel shell interaction that Rob talked about, and I think we've all done it, where you kind of knead the shell of the implant together in your hands, and you can see when you do it with the Sientra implant, it's still lubricated. The gel doesn't separate from the shell, whereas some other implants, it separates very quickly. And so the minute you get shell on shell, that's where you get failures. And so these things are real. You know, they're, even though that's a simple, like, very non-scientific test, it still is going to, if you do it in a scientific way, as Rob showed, you get the same findings. So I think they're relevant. And I agree, Bruce, you know, that, you know, the failure rate, that's an important thing. If the implant's going to last 20% longer, even, that's significant to a patient.
Absolutely.
Yeah, and I think that, you know, as wrinkling, if you think about wrinkling of an implant, you know, this improved gel to shell interaction and optimal fill has so improved that overall performance as it relates to that. And so I think it's become very, very important, that gel to shell interaction. And in the firmer implants, so in the more cohesive gel implants, that didn't have that interaction, there was a process of delamination often of the gel away from the shell over time too, which you don't see if you have integration of the gel into the shell.
Thank you guys all for your comments there. I think that's all very valid, and actually leads me into to go a little deeper into the implant technology. And then after we do that, I'd love to just discuss more on the techniques surrounding that, because I think it's worth noting that as an implant manufacturer, when I look at the data of what we did in the long-term studies that were designed by the FDA, really just show safety, not to show differences in techniques. Or when we've done data looks at specifically looking at techniques and doing multivariate analysis to pull out specific techniques, everything you guys are saying is comes through. So I'll share a little bit more about the technology, and then we'll go from there. So I think the last thing you guys talked about is the importance of this gel shell integration. I think this is something that is not to be understated, that if you saw the gel shell integration here, I mean, just visually, you can see that when in the lab, we look to peel the shell away from the gel, Sientra's gel actually never peels from the shell. So when we've quantified the force it takes to peel that, and therefore what it would take to delaminate in the body, we actually get a false reading that's too low, because it actually never peels cleanly. Whereas the Allergan and Mentor, and I'm showing shaped here, but the concept holds true for the lesser gels as well, that you get an easy and clean peel away from the gel in the shell. That doesn't just have to do with rupture. It for sure helps avoid rupture, because anytime you have a delamination, the shell separates. That's where more acute folding can happen, and more pressure over time is felt in a single spot. That's where failure happens in anything. It's kind of like having your shoe rub against the side of a single toe. That's where you get the blister, and that's where you get the failure. So this, I think, can see pictorially. So when we test the gel shell interaction of Sientra gel, it actually increases the strength between that bond increases as we get more cohesive. So the main thing to get out of this is that the gels are not all the same. There's a structural architectural difference in the chemistry of the cross-linked gel that allows a stronger gel shell integration and a more flexible or springy behavior of the gel. And that's what we see when we see this graph, is that you have a steeper slope of that strength to softness behavior with Sientra's gel, or their overall implant, than you see with the other two manufacturers. So this slope is actually 5. So basically, as you get more and more cross-linked, you get 5 extra units of strength for every 1 unit of softness you sacrifice in making it more cohesive. Whereas the other two manufacturers, very similar technologies, they get 2 and 3. And I want to point out that Allergan does have 3 gel technologies available on the US market today. And all 3 of those fall on the exact same performance curve. So each manufacturer can never get to a whole different curve without a completely new technology PMA. And so you can innovate all the way up and down your performance curve, but you can never innovate off of it. And that's why Sientra brings so much value to the market, is that the entire portfolio starts with a higher level of strength and durability, but optimizes the amount of softness you can get with that. That's also what allows us to cover in the long term with a warranty that covers patients, and it's really about patient confidence in getting the breast augmentation. Warranties are not meant to be used, but the better performance, the better long-term data that an implant can show, the better that our insurers and our financiers will allow us to offer coverage. So Sientra right now offers by far the best warranty in the market to cover both rupture in the long term and capsular contracture, as well as financial assistance for both of those, because we're so confident in the implant's behavior. And this is backed by the science in the lab, as well as the outcomes data that show that this is all benefited from the technology. So I'll stop there in terms of the presentation. And that's where I'd love to open it up for more discussion, not so much on the implant technology. I think we've talked enough about that, but really how you use techniques to optimize your outcomes. Again, one thing I want to go back to that Dr. Cohen talked about and Dr. Adams alluded to as well is that when you take a saline implant, the really overfilled salines is what we're dealing with. And when you overfill a shell, you no longer have the characteristics of the innards or of the saline in this case, but really the characteristics of that overfilled shell, which is much like an overly firm implant. So I'd love to hear your thoughts on how do you revise patients who have an overfilled saline, the tissues have been stretched, now are at risk of wrinkling and rippling, and you're going to replace it with a silicone gel. What are the techniques you use to control that pocket and that tissue overlay to get the best result? Let's start with you, Dr. Calobrace.
Well, in secondary cases, that's always the challenge when you got a thin envelope, but that's when you need an implant that actually performs the best and you can trust the most, because you're going to need that implant to hold its position. The only caveat I would say is when you get a big pocket, you must control that implant in that pocket. So I've talked a lot about, the ability to control and limit the pocket. And that's where, in some ways, surgeons have got into problems because they've tried to put a firmer, more optimally filled, sometimes a high profile, one of these gel implants into these pockets in a secondary case. And then they find out that they flipped and rotated and turned upside down and everything else because of that, because, it's a big pocket, kind of a round ball that's now firmer, trying to reduce wrinkling because of these stretched skin envelopes. And so I do think there's some benefit to having some softness to the implant too. So if you're talking about a smooth device, so it sort of holds onto the tissue, because when it gets too hard and too round, too smooth in a bigger pocket, you're going to help the wrinkling, but on the other side, you're going to have more problems with malposition of that implant. So I think there's always a balance with every device. That's why you got to be so selective about what is your soft tissue and what is your chest wall like, as you're sort of designing what your procedure will optimize the results.
Well, along those lines, if I can jump in here, Brad, what Rob showed us also was masterful in terms of handling complex. We all know these revision cases are the worst ones. We don't know exactly what's been done to the anatomy. Tissues were very, very thin. And I noted on 2 of your cases, Rob, you wisely dropped these people down from 650 implants to say 450, which is still a big implant, but it allowed you to do some corrections of that pocket that Brad's alluding to and really optimize it. John Tebbets taught us years ago that breast implant surgery, regardless of the type, is all about the soft tissue cover. And in these cases, whether it's due to the saline, oversized, high profile, and you overstretch these tissues, that's just absolutely a formula for problems, and we all see it and have to deal with it over and over.
I wanted to say just a couple of things. First of all, those were a little bit of outliers for my personal practice, in the sense that my average implant size is probably around 320 to 350 cc's. But obviously, if a woman's larger and has a larger base width, you go with a little bit bigger implant. So it's not like I'm typically putting in 450 and above. I tend to be more in the 300 low.
We were definitely judging you, so there you go. I'm glad you clarified that.
Yeah, and Rob, I want to know, how do you get away with that when you're in Arizona and Southern California putting in 300 cc? I mean, I love it because that's what I do as well, but I can get away with that in the Midwest. I'm just impressed that you're pulling it off where you live.
I've always been known for doing natural results. And so, I think it's really important to make sure the implant fits the patient, not fitting the patient to an implant that they want. So I tend to be a little bit more conservative. And I think that sort of drives that patient population towards me. If I get somebody who comes in who's really pushing for really big implants, I just don't operate on them. And if they want to go to somebody else, that's their option. But I try to explain why they shouldn't do that. And it's up to them. I wanted to go back for 1 sec because Blaine, you were talking about the warranty, and this is something I just really want to bring up specifically, because I get frustrated when I hear like people saying, "Oh, well, how can Sientra have this, such a good warranty? They're going to go out of business or this and that." I think there's two reasons why Sientra is always pushing the envelope with the warranty, and that's number one, better quality product. So your implant's going to have a lower rupture rate because of the better gel and the shell gel interaction, all that kind of stuff that we're talking about. Number two, and what I consider the most important point that just shockingly to me doesn't get brought up enough, is that who's putting these implants in, who's doing the work. That is significantly more important than what implant you're using. And the answer is board certified plastic surgeons. So if you have an implant and you're giving it to anybody who went to med school and wants to try their hand at doing breast augmentation because it's such an easy surgery, right? You're going to have a lot of disasters. But if you're limiting this implant to people who have proper training, and not that every board certified plastic surgeon is doing, following all the principles, but at least there's a much higher chance that they're going to be doing the things that need to be done, the 14-point plans and all that kind of stuff, then you're going to have a lower risk of complications. So those two reasons, I think, are why Sientra is always ahead of the curve with Capcom Care and this and that to advance the warranty. So I think it's a point that doesn't get brought up enough. To me, it's really almost like personally upsetting that more board certified plastic surgeons don't value the fact that you guys are taking a loss on business to try to make sure that you are keeping patients safe by not putting these in the hands of people who aren't properly trained. So I just want to make that point specifically.
Yeah, I appreciate that. And before I get back to you, Bill, because I definitely want to hear your comments on the clinical part. To us, we don't look at it as a loss of business, because it's a business that we never considered was worth going after because of the points you made. It protects us from having to pay out warranties as well. If we were giving these devices to anyone, that the rates of complications would be higher, and therefore it would be financially harder for us to cover that warranty. So that is, by design, that we want to work with the best surgeons, and therefore we can cover the patients for longer term because they're going to get better results. So I appreciate bringing that up, and it remains really the heart of our mission is to provide board certified plastic surgeons with the best technology and then cover them for it so they can bring confidence to their patients in signing up for that surgery. So thank you very much for bringing that up. But Dr. Adams, let's talk more clinically about this issue of revising patients with large implants. Do you go to another large implant or do you go to a smaller implant? What techniques do you use to control the pocket around it?
First, I wanted to comment to Bruce and Brad's comment. So I think I figured it out because Rob was telling us how he's got two practices. Actually, here's the deal. His average implant size in Phoenix and LA is like 450, okay? But he's got a third practice he's not telling us about. It's like an Amish community, and his average implant size is like 200. So that brings him down to the average of 350 across the board. So that's how he's getting to the 350. But
or he's in Japan as his
it's about averages. It's about averages, yeah. Mm-hmm.
Yeah. Anyway, I think a lot of this is very relevant. Again, I mean, I take it back to Rob's presentation, but some of these things, if you have a firmer feeling implant, because I don't think we can say, I mean, the Sientra implant's never flipped over. It probably does, but the problem is that, or not the problem, but the good thing is you're not going to feel it nearly as much as one of these firmer implants because of the science that Rob was talking about. So I think that kind of segues into the scientific conversation. But in terms of technique, Blaine, the soft tissue is a big deal. And in a lot of these cases, especially when they're stretched out, I'm usually doing something to enhance the soft tissues like Bruce alluded to. So I use fat actually in a lot of these patients as well, trying to, some closing down the pocket, some of the other things that Brad, Bruce, and Rob talked about, but then sometimes also adding fat because, no matter how good the implant is, I think we're all agreeing. I think Sientra is a fantastic implant, but it's not going to solve the problem for poor soft tissue coverage. And so, again, adding fat is some adjunctive thing that, can work well as well in many of these cases.
But, for a long time, I've always said, it depends whether you're a stuffer or you're a shaper as it relates to breast shape, right? And for the naive breast surgeon, if you're in the operating room and you're trying to make a result look good, and you're not really great at knowing how to close down pockets or do breast lifts, the easy thing to do is to fill up and put bigger implants in and fill up that space, because on the table, that's going to look better than what you're left with if you don't know how to control the pockets. Unfortunately, long-term, we all know that does not turn out well. And so I see why surgeons that are naive get there, because that's what looks great initially. And then unfortunately, we or others who do a lot of revisional surgery end up seeing those patients and the downside of that.
So true.
I think another point I wanted to make on sort of like a sort of parallel to that is you see these patients who have rippling, and the surgeon's like, well, the patient has rippling, so let me put in the stiffest implant possible because that implant's not going to contort, not really understanding that the rippling isn't caused by the implant rippling. Usually it's caused by traction rippling because the pocket doesn't fit the implant properly and they've lost control of the pocket. So as a matter of fact, you put a stiff implant in, it's just going to be a stiff implant in a ripply pocket still. And the key there is not necessarily a firmer implant, but it's tightening the pocket, shrinking it down, using popcorn technique, using reinforcement materials, using appropriate implant size, mastopexy techniques, fat grafting if it's possible. Obviously, that's very helpful. Using all those combinations of techniques to create a smoother, proportionate, natural-looking breast. And I agree, Brad. Like it's like what you were talking about. It's the same concept of the patients who are ptotic, and somebody's like, well, let's just fill that loose skin in with a giant implant. Well, then you're gonna have a giant droopy breast instead of a smaller droopy breast, which doesn't make any sense to me. So it's like sometimes I think some of these people who are doing these procedures aren't thinking about what's causing the problem before they try to solve the problem, and then they end up exacerbating it. You stick in a big implant in a patient with weak tissue or poorly controlled pocket, you're just going to stretch things out more and create more damage and make it even harder to fix the problem, whether it's a big saline implant or just a large, stiff silicone gel implant.
Could I follow up, Rob, on that thought? Also, with regards to primary cases, we've seen a resurgence of people placing implants subglandularly. And, those people like me that, are really old, I grew up handling all these subglandular cases that ended up with traction rippling, thinning, and part of that was due, in some cases, to saline implants and other, but it comes back to that soft tissue support. And the fact, like Brad says, how does it look on the table? Yeah, you do those subglandular augs on the table, they look good, but then look at them in 10 years when they've stretched and thinned and get the traction rippling you're referring to. So I have a personal peeve about this resurgent, largely by the younger surgeons who don't have that institutional memory of the problems we had with subglandular placement. I mean, I think there's, there are some patients, but I think the majority of the times, in my opinion, we're really better off with a good dual plane pocket and accept some animation deformity. Some of them don't want to see that, but when you look at the trade-off long-term, you're almost guaranteeing a reoperation down the road.
No doubt, no doubt. And I think the other thing about it that is seldom talked about but relevant is that all these people on down the line, the majority, no matter what, it can be 10, 15 years later, they need to have other things done. And the minute you do a subglandular pocket, you've changed the blood supply of the breast. And then, they're in your office, Bruce or Brad or Rob, and you're like thin, paper thin, need some mastopexy. You're wondering if you can do it. So I totally agree. I just think it's not that you can't do a subglandular pocket plane, and probably with the proper technique, you can probably do it and not get capsular contracture with current techniques and current implants. But it's what happens 10, 15 years later when you come back and the blood supply of the breast is so much better if it's under the muscle.
Absolutely.
Yeah, and I was just going to say that, and I think where a subglandular implant sometimes was really effective was in a more constricted tuberous breast, often because you really wanted to get to all the breast tissue. And by the time you did a dual plane, you were a dual plane 3, and you want some of the stretching of that very, very tight tissue. So the negative consequence in most breast augmentations was sort of a good addition in that particular procedure, and they do quite well. Or even using a shaped implant in a day in that type of a patient was great. But outside of that, the consequences of going on top of the muscle, and there's been a lot more people doing it. And in Canada, I just reviewed a paper for ASJ as it relates to that and trying to show, the effectiveness of it. But, a 1 or 2 year, data point isn't nearly long enough to see the long-term consequences.
Dr. Steven Sigelov is part of my Arizona practice. He's one of the pioneers of pre-pack reconstruction. And so he does subfascial and he does, pre-pec stuff, but the key for him is he's always using reinforcement materials at the same time. So it's not just sticking an implant, proper implant selection plus patient selection plus reinforcement. And then you can mitigate a lot of those problems that you might have if you just stick a subglandular implant in and kind of hope it's going to do okay.
For what it's worth, this is beautiful discussion, you guys, and it's something that will go on in future sessions a lot more in detail as a subglandular versus submuscular. I think it's clear, though, like you said, the device choice matters. If you're putting a really, really big implant, it's going to have more of the problem Dr. Adams alluded to with tissue atrophy and stretching that out, versus if you're going with a smaller, sensible, natural look with some tissue reinforcement, subglandular may be a very relevant way to go for patients who want that. So one thing I'd love to go back to before we close up for this session, because we'll go deeper into all of these things in future sessions, is this idea of filling the pocket that's already been stretched, or just patients who come in, if you're in Southern California, or you're somewhere where patients just want a larger implant, you have to find sensibility with what they want versus what you're willing to give. And this idea of a cohesive implant, filling it out, and then the flippability, there's really three factors that we've identified. First is pocket dissection. The bigger the pocket dissection for a smooth implant especially, the easier it is to flip it over. Second is the projection of the implant. So the higher projection, these extra high projections are more round to start with, and they're easier to flip. And the third, which I think is probably, these are each contribute not necessarily a third. The smallest one is the implant behavior itself. So if you're able to control your pocket, but you still want a ultra high projection, having that flexible gel is going to make it less likely to roll over. And the concept there that I think of is, if any of you have bought one of these foam mattresses that are out there now, if you try to flip that over by yourself, I mean, you have to roll it over. It takes a lot of strength to flip that over because it's flexible. Versus if you flip over a box spring, because it's stiff, it hits that fulcrum and it's ready to flip right away. And I think that's a good way to think about it, that it might be the most minuscule detail in that, but if you're already decided that you have someone who's overfilled saline, so your pocket control is a little tougher, but someone who really still wants that extra projection, that implant flexibility may be the only factor you have to save them from flipping. So I'd love to hear you guys' comments on that.
That's where texture helped us, back in the day of textures. But, so when you don't, texture would have helped us. So with smooth devices, maybe using some reinforcement as well, and those type of pockets can also be beneficial. Bill?
And the texture is still available with Sientra. So let's not forget that. That'll be, again, another session, but completely differentiated texture with Sientra and the benefit to risk ratio. But yeah, Dr. Van Natta, what are your thoughts?
Well, all I want to say, Blaine, is I've been talking about implants now for 30 years that I've been in practice, and I've never in the same conversation heard a comparison of an implant delamination to a blister on a toe or to a foam versus a regular mattress. I'm just really fascinated by the analogies you're using.
I don't like blisters and I have a firm mattress. That's my disclosure.
Well, this is, and so Bruce actually, I was a medical student. Bruce is my senior resident at that time. So he's been doing this a long time. I'm really very young compared to him. So I figured, Bruce, you'd heard everything already.
Yeah, I hadn't heard those.
All right. Dr. Adams, what are your thoughts on this, on the need for big implants? How do you control it?
No, I mean,
he's in Texas.
Big implants cause big problems. That's what we tell the residents. My main question was, Blaine, are you talking, is it Tempur-Pedic or is it like a purple you're talking about?
No, it's these new foam mattresses that are only sold online. I'll send you a link, but they're great.
Maybe we'd be a little. We'd probably be a little remiss not to mention. I mean this seriously. Is that Bill is on this call with us, and he really published one of the pioneer papers that talked about the process of breast augmentation. That's cited over and over again. It's on the in-services and the importance of all the 4 steps. Starting with patient education through preoperative planning, operative technique, and postoperative care as it relates to that. And part of that is sizing a patient. It's part of it, and all these other conversations that go into it. Each piece of those. In the puzzle, and I think that Bill has done the same thing for augpexies as well too, in reminding us that we're going to have to step back and in a processive way go through and make our decisions, because there's good decisions and bad decisions all along the way. Sizing being one of maybe the most obvious ones that we see.
Yeah, I mean, I think that just in general, if you pick implants that fit people's breasts, whether it's primary, revision surgery, that's going to serve you well. And I think that the other panelists have really articulated it very well, that sometimes you have a problem just putting in a bigger implant, even though that's not what the patient thinks the solution is.
Right.
That's probably not the best solution in most cases.
And,
All right.
and the other thing I would say is most surgeons, if they could become really comfortable with doing mastopexies with their breast surgery when they need them, they'll go a lot further in getting a great result. The temptation to not do a mastopexy because of some fear of how to get a great result. And I think in a future one of these meetings we're going to cover that too, because I think that really opens up the opportunity to get a much better result and downsize patients to give them a more optimal outcome for long term.
Well, this is great discussion. I think you said it right, Dr. Calobrace. We have a lot that we can go into in more specifics on future sessions. So I thank you guys so much for your time and in sharing your results with us here. Any final thoughts? Let's go around the horn. We'll start with Dr. Adams. Final thoughts on the discussion so far.
No, I think it was a fantastic discussion. With the science, you have to kind of take the science and you have to take the clinical, and those have to kind of fit together in order to give patients their best results. And I think that's what we've brought out in this discussion. I think it's been great. And thank you for putting it together, Blaine.
Yeah, thanks for joining us. You're obviously an excellent contributor. As Dr. Calabrace said, you've written on this for a long time, and it's really, that needs to be looked at. As new technologies come on, you have to reevaluate everything we've done in the past and in the new era. So Dr. Van Natta, final thoughts here?
Well, I would just echo some of what we've already said. You can have the best implant in the world, and I think all of us agree that the technology behind the Sientra device is exceptional. But if you don't do things right technically, if you put too large of an implant and so on and so forth, it doesn't matter how good the implant is. So the implant can't make up for poor technical expertise. So you got to have both components to have a great outcome.
Great, thank you. And Dr. Calabrace.
I would just say that for everybody listening, until you retire, keep learning breast surgery. I continue to learn and become better. We were having more devices, more techniques, and we're sharing that. A lot of us are publishing on that. Keep learning like I am, because we can get better and better at this. And all four of us who are talking here do a lot of breast surgery in our career, have done a lot of breast surgery. And there's a reason for that, because we're achieving optimal results for patients over and over again. It's not okay to every once in a while get a great result and put it on your website. You've got to consistently over and over again be able to create successful outcomes for your patients if you want to be successful in breast surgery. And we're here to help you along the way. And I love these kind of conversations. So thank you to Sientra and you, Blaine, and all of you guys for being part of it. It's great.
Yeah, thank you too, and well said. And Dr. Cohen, thanks so much for presenting some of the science and data behind why you make the choices you make. Any final thoughts for this discussion?
All of us on the panel here do a lot of speaking and teaching. And when it's been many, many years that I've been doing this. And what I found was that if you're going to talk about something in front of an audience of surgeons, you better know why you're specifically doing every single thing you're doing. You can't just say, it's because I have how I do it. You have to have a reason behind it. And so what it does is it forces you to really assess and evaluate every technique you do. And is this the best technique? And even if you're not on panels and speaking a lot, that's the concept you should apply to your practice. Don't just do stuff the way you've done it because that's how you do it. Find out, like see how your patients are doing long term. If there's things that can be improved or changed, update your techniques. Like all of us are constantly learning and constantly advancing what we're doing. I don't think any of us do things the way we did even maybe 5 years ago. So that's really the key, is continue to advance, not just in terms of techniques, but in terms of technology. And that's why I like how Sientra is kind of always pushing the envelope in terms of best technology.
I appreciate that so much, and I appreciate all your comments today. I've learned a ton from you guys, and really that's the mission of Sientra, is we're learning from you. So really a true partnership that's based on optimizing these techniques first, as you said, is the most important. And so that we can evolve the technology to follow that, I think, is the optimal result, rather than chasing connection to injectables or anything else. Let's find the best breast through techniques and technology, and leave it at that for patients. And then as a community, we can learn together and improve overall. So I thank you guys so much for joining us today. And I hope to have you back on future panels, and look forward to continuing this conversation more specifics.